Good morning, everyone. It's a real pleasure to be here and certainly an honour to be asked to present the Tuesday morning lecture. I've been travelling back and forth here a few times over the last few years and always been impressed and have really enjoyed watching the expansion and the development of things here at Aspetar. It's been fantastic. And this morning I wanted to share some thoughts, particularly considering around how we can optimise our prescription of load, mechanical loading during the rehabilitation process. How can we maximise adaptation? And is there a way in which, if we get that right, can that have an influence perhaps on preventing recurrence of injury, which we know is a challenge. And we've known that for a very long time, that we've seen that many times that the greatest predictor of injury is that you've had it before. And if we go right back to some of the older 20 years ago, now the research from Oslo and Professor Barr and colleagues, we looking at ankle sprains, we see that just after return from sport is where you're at greatest risk of re-injury. And we know that, we see this similar, I could put up similar graphs perhaps for things like hamstring injuries or for many other musculoskeletal injuries. And we recognise therefore that re-injury is a challenge. And often what's levelled at our door as a criticism potentially is that many of the times that people re-injure because of inadequate rehab. Now, what does that mean? Because that's often a challenge to us about inadequate rehab. Well then, in that case, what is adequate rehab? What are we trying to achieve from a rehabilitation? And what is a good rehabilitation outcome? And what factors at a basic tissue and function level do we want to achieve in order to ensure that we get good rehabilitation outcomes? And so I think that at the heart of that is this concept of loading or optimal loading. And optimal loading I have defined previously, and I think is that it's a pretty broad description, but it's the nature, direction, magnitude, intensity, frequency and duration of applied load to affected structures that, number one, maximises physiological adaptation, and secondly, restores function. And if we keep those two key things, I think, in mind, it's pretty critical that we want to maximise the physiological adaptation. So how can we use loading and mechanotherapy to maximise our physiological adaptation? The key thing, however, is that we must be cognizant of the fact that it's not just about getting tissue restoration, but that has to be integrated back into function. And particularly in the context of sport, it's having healthy tissue that is easily integrated back into the broader neuromusculoskeletal system to facilitate effective function and prevent recurrence of injury. Now, there are many variables that we can manipulate in order to achieve better loading. And those are things like the nature, direction, magnitude, intensity of that load. So I wanted to consider what factors contribute to good outcomes and can optimise loading during this rehabilitation process. Well, as Stephen Covey reminded us in 7 Habits of Highly Successful People, habit number 2 is to begin with the end in mind. And it's very important when beginning a rehabilitation journey or beginning any project that you begin with the end in mind. It's quite remarkable that I think that sometimes when we begin the rehabilitation journey or our intervention as clinicians, be they as physicians, physiotherapists, trainers, whatever profession we may come from, that we always have to consider what is the end goal. So what is the end goal? And then to consider some key factors. What is the tissue type? Is it different loading strategy and an approach to rehabilitation for muscle versus tendon versus bone or ligament? What's the implication of that? What's the pathological presentation? Is it a chronic problem? Is it an acute traumatic presentation? What's the nature of the activity to which the athlete must return? What are the loads and the stresses, the particular skills that they must engage in? To consider these factors, I think, is critical and central to our planning and optimising of load. And then we've got to, once we have a really clear understanding of the nature of the activity, the function of the tissue, the pathological presentation, then we can start to consider, well, what adaptation do I need to achieve with this patient to move them from this point to an effective return to sport and minimise the chances of recurrence? I think unless we begin very clearly, then we won't finish well. So if you begin well, you'll finish well. I really like this slide. I like this statement from the paper at the top there, is that mechanics rule cell biology. And as experts in the prescription of exercise, I take great encouragement of the fact that exercise or mechanical loading not just works at a broad level, but it works right at a cellular level. It works at a biological level, and we know the concept of mechanotransduction, with which many of you are very familiar, that mechanotransduction is the concept of the idea where mechanical movement or mechanical loading converts signals into a cascade of events that change cellular and molecular processes. And we know that there are complex processes involved in that. We know that as we load, we challenge the extracellular matrix, the cell itself, we change at a cell nucleus level, an upregulation of mRNA, that we can change gene expression, and we can change tissue at that cellular level by the appropriate prescription of exercise. But the key thing is, we've got to get the right balance. It's the yin and yang, if you like, of balance, because too much, we know isn't so good, and too little, we won't get the appropriate adaptation. And so how do we get the balance right, and how can we optimize that balance of loading and the type of loading in all of our patients? Well, first we've got to understand, I think, how mechanical loading stimulates response, then take some considerations, and I've got 3 or 4 broad principles of how we can optimize load during the rehabilitation process. So how do mechanical loads stimulate adaptation? And there's a really nice review last year in physical therapy by Thompson and colleagues that outlined this process, and it's really quite nice. Well, we have this mechanical stimulus, first of all, that then applies tissue forces, or forces across the tissues. As the forces in the tissues are transferred, therefore, to the cellular level, and ultimately we get a molecular response. Well, so how does that happen? How does that work? Well, we know that the tissue mechanical properties, so the stiffness characteristics or the viscoelastic properties of the specific tissues, will determine the direction and nature of the loading at the tissue level. We also then know that the cell mechanical properties, so the integrins and the extracellular matrix and the extracellular structures, will have an influence on the mechanical properties and the forces that are transferred through the cells. And so we see then that we get an alteration in the cytoskeletal arrangement, and so we think of something like a tendon cells, we get changes in the tenocytes, in their alignment, in their arrangement, which has a knock-on effect and influences the tissue forces, and we get, if you like, a change in this recursive loop where the extracellular matrix is synthesized or degraded depending on whether the load is excessive or appropriate. And so we can take great encouragement to know that when we're prescribing specific exercise or specific loading of a tissue, I think we can take great comfort and encourage ourselves that when we're prescribing exercise, it's not just exercise. It has a very powerful response at a really deep cellular and molecular level within the body. So our goal then is to try and maximize that response. There's good science underpinning it. So it's about balancing this idea of load and rest. What's the appropriate amount of load? What's the nature of the load? It's that mechanostat. The term mechanostat and the idea of mechanobiology has been around since the late 1800s. We haven't invented it. The body has always responded to load. There is no such thing as a vacuum in the human body or its response to loading. There is either loading or the absence of load, and the body will respond to that mechanical or absence of mechanical stimulus, and it will adapt its tissues appropriately. So have we got some principles then to help guide our exercise prescription? Well, the first thing I would say is that optimal loading is early loading. Okay, so how can we achieve that optimal loading in rehabilitation? So the first thing I would say is optimal loading is early loading. I'll say it again, just for 3 points, it's good to work in tries. Optimal loading is early loading. We'll see if hopefully you remember this by the end. So when we look at the clinical evidence and we look at good quality randomized controlled trials and clinical studies across different tissue types in injured clinical studies, what we see is actually not fantastic good clinical studies for muscle and tendon in injured populations that give us strong evidence of whether we have, and PNR is about protection, rest and loading. So the idea of how much rest, how much load. Most of the studies that have been done have related to joints, often associated with post-surgical interventions, and particularly around the knee and the ankle. We see many of them. And what we see is moderate evidence that a functional approach is better than immobilization. I think it's a challenge to us if we're considering clinical research moving forward. We've got lots of really good healthy subject studies. We've got good basic science studies looking at muscle and tendon, but actually doing it with injured subjects, putting in specific loading protocols, compare and doing a randomized controlled trial in a proper clinical study, we're still pretty lean in terms of muscle and tendon. So I think it's an important area to look at. However, if we look at some of the basic science in the animal studies, we start to see a little bit more. And particularly then, if we look across, this was 12 studies that myself and a colleague Chris Blakely did on behalf of the UK Physios and Sport group, where we did a broad review and meta-analysis of these. And when we look at these 12 studies in particular, where we favoured outcomes, or we looked at outcomes compared to early exercise versus immobilization or protection and rest, what we see is overwhelmingly, and this is the time post-injury in days across the bottom here, overwhelmingly there was evidence in favour of early immobilization and early exercise. So in terms of outcomes at a basic science level, and if using animal models at a tissue level, we know that movement is better than immobilization in terms of longer term outcomes. So what does that look like? Well, in terms of ligament loading, what we see here, and I won't go into too much detail in this study, but this was a rabbit model in an MCL. And here we see the normal stress strain curve of repeated cyclical loading of a ligament. And what you see is this idea that you get a tiny little bit of normal hysteresis and creep, but not anything too significant. Similarly here, we see, when we compare that then to a 6 week, after 6 weeks of immobilization, you can see the difference consistently between the healthy control and after 6 weeks of immobilization. What you see is a significantly greater amount of creep. So the mechanical properties of the ligament are very different. In this study then, they induced an injury, and in this instance here, we see free ambulation, so early mobilization versus immobilization in this cyclical loading. We see for sure there's a change in the stress strain curves following injury compared to the control or the normal group. But look at the difference, which is pretty significant, I think, between the stress strain curve here of the free early immobilization versus the immobilized scar. And what you see for the same amount of cyclical, submaximal cyclical loading, very important. What we see is that after only 17 repetitions in the immobilized ligament, we see complete rupture. So I think that what that tells us, that getting moving earlier increases the mechanical properties and strength of the ligamentous tissue. What it also tells us that following immobilization, even cyclical submaximal loading can have a profound effect on the integrity of the system. So I would encourage us, therefore, to consider the number of repetitions and how many cycles of loading that we're doing, not just think in terms of the extent and the intensity of that loading. Okay? So it's not just intensity of loading, but frequency of loading that will be important. We see the same thing again here in a model that looked at rat tissues, and we see the control group here. We see ambulatory healing, suspended healing, so we removed all loading, and we look at the modulus, and what you see consistently again is that the tissue is stronger whenever they are able to move. And this is ligament again, and whenever they're able or encouraged to go to free ambulation early. So early mobilization, early loading facilitates mechanical outcomes. It not only facilitates mechanical outcomes, but it facilitates, I think, structure and histological outcomes. And so we see here across normal tissue, control tissue, when we look here, this in the B group corresponds to this group, the ambulatory group. What you see at 3 weeks here and at 7 weeks, a much more parallel orientation and organization of the tissue in the ambulatory healing group. For the group that was immobilized, look at the disorganization and the lack
of a parallel orientation of the ligamentous fibers. So the lack of early mobilization leads not only to poor mechanical outcomes, but I would argue as well poor histological and structural outcomes. So if we load early, we get better fiber alignment and therefore greater tensile strength. If we think that's of ligament, we think of muscle. We know when we unload muscle, and we've known this for a very long time. Jeff Goldspink's seminal work back in the 70s and early 80s, when he considered many of the things that we now use every day in our muscle rehabilitation, we know after only a short period of immobilization or unloading of muscle, that muscle adapts very quickly. And we know that if we unload muscle, that very quickly we will reduce our angle of pronation and our fascicle length. Similarly, we know that when we're considering rehabilitation, when we load muscle early and we load it with specific strategies, one of the key, or two of the key adaptations that we're looking for in terms of injury prevention with muscle is to increase angle of pronation and increase fascicle length. In fact, I remember Jeff Goldspink many years ago at a muscle injury think tank that we hosted in the UK, and him making the statement that within 24 hours, your sarcomeres start to change. He said that if you've never worn high heels before, which I can honestly say that's never happened for myself, but if I were therefore to wear high heels, bad image, I appreciate. So if you were to wear high heels and never had worn them before, that within 24 hours, you would start to lose sarcomeres. Okay. So after a very short period of time, muscle adapts very quickly to load or the absence of load. So I would argue as well that choosing to remove loading from tissue is actually a prescription. And we have to justify the prescription of the absence of load as much as we justify the loading. Yeah. So don't think of it as whether we're immobilizing or loading. We're saying what type of load are we applying, and is that the absence of load or the presence of load? And so we know that with muscle, when we compare the mechanical outcomes versus early mobilization group versus an immobilization group, again, the strength increases significantly with the early mobilization group. So following, and again, this is an animal model. So we're looking at early loading of animal tissue. We see significantly stronger muscle tissue compared to groups that are immobilized. Again, these are studies that we need to do in human subjects and that we need to do clinically and look at some of the real comparisons so we can really refine our exercise prescription. Because in this, they were immobilized for 2 days, in this day 21 days. I don't know anyone with a muscle injury that is immobilized for 21 days. So we've got to refine things, but it's a key basic science principle that we're considering. What we know then, it changes the presentation, not just at a mechanical level, but we're also thinking as a stimulus for capillary ingrowth. This Jarvinen's sort of seminal paper in American Journal of Sports Medicine in 2005 highlighted the difference in following a muscle injury. And again, this is an animal model, but it presents some very key principles, that what we see in mobilization, we get good intensive ingrowth of new capillaries. We get a reduction in the size of the hematoma towards this non-vascular center. Contrast that with the immobilized group. We've got a big hematoma here. We get reduced capillary ingrowth. We get increased scar size. So getting muscle moving early is important. So optimal loading is early loading. And some of the benefits of early loading, we've seen it for ligament, we now see it for muscle. You get better intensive capillary ingrowth, better regeneration, more parallel orientation of the muscle fibers, less connective tissue, improved biomechanical strength, and less atrophy of the intact, healthy fibers. So for me, getting muscles moving early is not a question of whether we should do it, it's how we do it. Okay? So early loading is optimal loading. But we've got to consider what's happening when we think of the concept of optimal loading, of what's happening at a micro, meso, and macro level. So at a micro level, we know that we're affecting what's happening in the cell. Through the process of mechanotransduction, we can change the collagen synthesis, we can change the tenocyte and the ribosomal RNA. We can upregulate that and change things at a cellular level. We know that at a tissue level, we're getting neural effects, better activation. We can change systemic effects in terms of things like endurance and cardiovascular fitness. We can get hormonal effects we can drive those by movement, and that will stimulate things in muscle like hypertrophy. But fundamentally, what we're thinking about is improving function for the athlete. because they need to return back to sport and do so well and do so healthily. So how can we prescribe loading more effectively? Well, we use lots of things every day, and we use many different ways to apply load. There's different ways to apply load. A number of years ago, again, we decided that the acronym of PRICE, of protection, rest, ice, compression, and elevation, and when we use the idea that rest as being intervention, is actually suggesting that the absence of load is a good thing. But the overwhelming basic science evidence tells us that early loading is better, optimal loading is early loading. So what we decided was that let's take rest out of our mind and think about optimal loading, but we've got to maintain the protection component. So it's protection. So protect the structures. I'm not saying do things that might compromise structures. Certainly protect the structures, but now consider how can I optimally load should be our first question, because that will drive the adaptation. So we do know that actually by application of our hands in some manual therapy, potentially at a joint level, and there's some basic science work coming out from Tom Best's lab in Ohio State where they've looked at some of the cellular responses to massage-like cyclical compression that's driving things at an early stage. So there may be a role for using some sort of hands-on type work to drive early adaptation, but that again will be limited in its ability. We may use things like shockwave. Is a mechanical force, it's a mechanical load, and it will get a mechanical response. There's conventional ways of loading in typical strength training. But I would also argue that the use of braces and crutches or supports is a good way of facilitating early loading. I don't view them as a way of unloading, but a way of optimizing load. So I can reduce the load to the injured tissues, but facilitate appropriate gait or partial weight bearing. So I'm getting some weight through the area or some load through the area. And so we think of it as a way to facilitate loading, not to prevent loading. Perhaps we might use some muscle stimulation or typical exercise prescription. So there are lots of different ways that we can apply load that go beyond just weightlifting. Number 2, optimal loading is tissue and adaptation specific. So optimal loading, number 1, is early loading. Number 2 is tissue and adaptation specific. It's not a generalized loading strategy. We're being very intentional about which load we select and how that creates the adaptation. So what are the characteristics of optimal loading? What are the key variables and how can we stimulate certain mechanisms? I want to consider that for a few minutes. So we recognize that there are many variables, the nature, frequency, duration, magnitude, intensity of that load, and that will have a cellular effect, and it will also have a neural effect. Well, obviously cellular in one sense in the nervous system as well. And then the mechanisms by which we get our adaptation will be some of the mechanical mechanisms that we talked about. We might get changes at a metabolic level, a morphological change. We get changes in function, and always bearing in mind of the importance of loading and exercise and movement, and the importance that that has as a psychological component and the experience of movement and the benefit for our patients. So if we look at some of those, first of all, and we consider some of those loading variables, how then can we make better decisions to address different tissue types? What guides our decision making? What guides our decision making when I'm treating a muscle versus a tendon versus a bone? So we've already considered some of the adaptations in the early stages for early loading for ligament and for muscle. And so now I wanted to consider, well, some of these loading variables and mechanisms for firstly for bone and then for tendon. So if we think of bone, do we have any information that will enable us to make better decisions about the nature, magnitude, frequency, direction, duration, and intensity of load for the stimulus of bone healing or bone adaptation? Well, firstly, we've got to consider how is the tissue being loaded. So when we prescribe loading, what type of loading is it? And this is a lovely slide, again, from that same Thompson paper in physical therapy, where we look at, is it tension, compression, shear? Is it hydrostatic pressure, vibration? Is it fluid shear? Not all loading is equal. And the loading that we apply to the tissue should reflect the demands of function on those tissues. So is the tissue being loaded in an appropriate way? Compressive, tensile loading, shear loading. How will your prescription of loading reflect the type of loading that tissue experiences during normal functional activities? So how can we stimulate better bone and adaptation, and is there any information that we can see? Well, the first thing that we see is that we need an appropriate strain magnitude for load, for adaptation in bone. We know that normal everyday loading may sit somewhere between 50 to 200 and up to 2,500 and in terms of bone strain. What we know is that we have to exceed normal average everyday loading to get adaptation. Okay? So we have to live in this zone somewhere if we want to experience a change. The load has to be of a great enough magnitude to stimulate an adaptation. And if we just load it the way it's always loaded, we won't see a change. And the bone responds when it differs from normal methods of loading. So what we have to think is, what does the athlete normally do? Now, can I find a novel way to apply load to that bone? So a new movement, a new exercise, a new intensity of exercise. And is it of a high enough magnitude to stimulate a response that sits outside, if you like, this physiological window? So loading magnitude is key, and it must be novel. The second thing is it should be dynamic. Again, this is a really nice study. What we see here is static loading and dynamic loading of the humerus, and it was a humerus, again, an animal model. But what we see is that in the static load, there was 360, if you like, cycles of loading, but it was done in one block, versus 4 times 90. So the same total number of cycles of loading, but done in 4 sets. And what we see here is a significant increase. So this was the original bone here, versus then the new bone and adaptation. Compare that then to here. You can see a small increase, but minimal increase in bone load. We see cortical changes as well as sort of periosteal level changes. And we see that it's significantly greater when we do it with intermittent episodes of loading. So whenever we have one consistent 360 repetitions of loading in one bout, there was a 64% increase in ultimate force and a 94% increase in energy to failure. That's pretty good. We would look at that and think, if the story was left there, we would be happy. However, can we do it even better? So the same number of repetitions, but done in 4 blocks, well, we got, and it was 35% higher than the one bout group in terms of ultimate force, and 75% higher in the energy to failure and static loading. So significantly better when we do it in short bouts. So if we load bone, I would suggest let's do it little and often. We will get much better adaptation than if we just load it in one go. Yeah. Again, loading frequency. So the hertz, how many repetitions, how often do we do it? What we know is actually that the threshold for bone formation is significantly lower when our frequency is higher. So if we have low frequency loading, we have a high threshold for bone formation. When we load with higher frequency, we get a better adaptation. So high frequency loading is better than low frequency loading. So again, high frequency, little and often, novel loads to get bone adaptation. The classical studies show us in tennis players and baseball, we see changes at a humeral level, and humeral bone density and humeral bone characteristics in baseball pitchers and tennis players. We see consistently that what we see is that actually they give changes that last right through the lifespan, and that's the periosteal changes that tend to last for longer, whereas the more cortical changes tend to reduce over time. So we know that if I am someone who unilaterally loads or has very focal loading of a bone, then I get adaptation. But the point that I would take from that, and again we've seen it in many other studies, experimental studies, is that the adaptation is site-specific. The loading adaptation is only in their humerus, it's not in their contralateral humerus or in their hip, it's where the load has been applied. And again, lots of studies have shown that it's very specific and it's very site-specific. So think about, how is this loading addressing the area that I want to change? So it's very site-specific. So a few principles. How can we load bone well? Number one, it has to have sufficient overload. It has to sit outside the norm of what they have every day. Number two, novel loading is better. So something different, a different direction, a different movement experience. It has to be dynamic. Dynamic is better than static loading, little and often. High frequency loading, and remember the adaptation is site specific. Okay, so that's some of the things that we might consider if we want to optimize loading in bone. So what about tendon? Well, what mechanisms do we want to perhaps address, and how do we want to get our adaptation and maximize that within tendon? Which mechanisms do you want to stimulate? Well, I come back again to the question, well, what do you want to achieve? What are your goals? Is it about changing the movement capability, so integrating that tendon function into the activity? Or are you trying to change the tissue capacity? Are you trying to get specific morphological changes in that tendon tissue? So I often use the question, are you training tissue capacity or movement capability? And they will have distinct approaches, but both are important. We can have a tissue that looks very good under a microscope, but if we can't integrate it into function, that tissue will not be loaded appropriately. So how does tendon respond to bone? Well, Peter Magnussen's group and the group in Copenhagen did some really nice work a number of years ago, and we look at this and we know that after loading of tendon, we see a synthesis and a degradative process. And we know this applies for most biological tissues. So you get a process of synthesis and degradation. And that over time, we want to hopefully sit within net synthesis at a certain time. So it tells us again, we balance our load and unload. Now, if we overload, then we will increase our degradation. But there appears to be a limit in the amount of synthesis that we can achieve. There isn't a limit, unfortunately, in the amount of degradation. If you continue to load it, you will continue to get degradation. But there appears to be a ceiling in the amount of synthesis. And this was really well illustrated in this study that, again, the same group did, where they looked at tendon collagen synthesis for 3 different exercise protocols. And looking here, first of all, at doing 10 sets of 10 repetitions at 70% of the 1RM in a quads extension movement. Then there was 1 hour of maximal free kicking, again, on a quads extension. And then there was a 36-kilometer run. 3 very different types of loading. What you see is that essentially they got the same amount of tendon and collagen synthesis. Now, if I'm a patient, I know which exercise I would prefer to do to get the same adaptation. So there appears to be almost a little bit like an on-off. This is the amount of upregulation of tendon collagen synthesis that we will achieve. So I would argue in the rehabilitation process, what's the least amount of exercise that we require to achieve the maximum amount of adaptation, so that we're really efficient with our selection of exercise. And so you can imagine the amount of tissue degradation you're going to get after a 36-kilometer run versus after this 10 sets of 10 repetitions, which is still quite high, and I would argue. It would have been interesting to do a similar study of about something that was like 3 sets of 6 repetitions at maximal load. I think we might have seen similar adaptations. So what's the threshold for adaptation? But we recognize that when we're getting effects at a tendon level, it's more than just the mechanical effects. We know that when you have a tendon injury, that there are many sensory and motor deficits. And here consistently, again in this systematic review and meta-analysis in BJSM a few years ago, we see here that there is a significant reduction in that cortical drive and sensory and motor characteristics. Those deficits are obvious in people with a unilateral tendinopathy. So if we're trying to optimize our loading has to change the tissue characteristics, but it also has to do something about those neurological effects of the injury. So we've got to load the nervous system and the sensory system, as well as loading just purely the mechanical system. And Jill Cook, who many of you know, and I know she's been here many times, and Craig Purdom sort of updated and revisited the tendon continuum model. And this is quite nice, and I think it illustrates the point very well. You can have pathological tissue within the tendon. That can be painful, but it is not always painful. We know some of those degenerative changes, and we know that idea of having acute and chronic components within or reactive and degenerative components within a tendon. We can have pain, and also there's poor function. So actually that sort of squares with what I started off talking about. This is tissue capacity, movement capability, and then we put on top of that the pain of the athlete, the pain of the patient. So if we think about which of these three different things you're trying to address should guide your choice of loading strategy. So if someone has got pain, we select an exercise intervention that helps reduce their pain and maximize their motor unit recruitment and reduce their pain sensitivity. If, however, we're trying to get tendon cellular or mechanical characteristic changes, we use different type of loading to achieve that. Heavy slow resistance training, eccentric loading. If then we're talking about the stretch shortening cycle and the elastic modulus of the tendon, we use different strategies to achieve that. So for me, it's not an either or, it's just which exercise do you select for which outcome you want to achieve. And so we move very clearly, we know what is the required capacity. So tissue capacity is important, and we need a stepwise progression for that, but it's more than just tissue capacity. It's movement capability and the pain modulation that we need to consider. And we know that even by choosing the right type of loading, we can change and affect pain and function. Ebony Rio's work, for example, looking at isometric contractions, induces analgesia and reduces inhibition in tendinopathy. So we're loading for tendinopathy, but the changes that we're experiencing are not at a tissue characteristic level at the tendon, they're happening at a neurophysiological level in terms of analgesia and reduction of inhibition. So we needn't always think that the application of load has a mechanical response. It does, but it also has a neural response. And it also, therefore, if I've reduced pain, I have a psychological response because my experience of that movement is quite different. So our loading can hit lots of things. So we thought about what we want to try to achieve from a pathological presentation. We're changing from a neurological presentation, and what we think of what changes do we want in tendon from a mechanical presentation. So what stiffness, what's the optimal stiffness of the muscle tendon unit? And we know we're always striking the balance of the appropriate blend of compliance and stiffness within the tendon. And we know that tendinopathic tendons, degenerative tendons, tend to be more compliant, less stiff, less springy, if you like. And our goal is to prescribe the right type of exercise or loading to enhance that, to find optimal stiffness. Because if we're too stiff, that's not good either. It has to be person, context, activity, and tendon specific. And we've got to therefore understand key relationships of how muscle and tendon interact. Tendon does not live on its own in space. It's always attached to a muscle. And it's the stiffness of the muscle tendon unit. And if we understand the length of the working muscle and the speed of that muscle and where we can harness the elastic recoil of the tendon, then that will give us a good adaptation. So we have to understand when we're prescribing exercise from that functional characteristic of the stiffness of the muscle tendon unit, the passive tissue characteristics within the tendon, but also the active characteristics of the activation of the muscle. And so if I prescribe exercise at one end of the spectrum at low velocity, at strength, that will be really important to increase muscle strength and put some load through that tendon. If, however, I want to return to a high-speed, multi-directional sport, I've got to move at some stage down into this spectrum of adaptation to change the recruitment of the muscle and how it interacts with the tendon. So what adaptation do you want? How do you want to change the force-velocity curve of the muscle? Am I looking for increases of force generation at slow speeds? Or am I looking for the ability to generate higher forces at high speeds? The term that some trainers talk about is you surf the curve. Where on this force velocity curve do you want to get your adaptation in terms of muscle activation and interaction with tendon? And we know that if we work at certain points of this curve, we get different types of adaptation. So for example, we get increase in tendon stiffness characteristics with plyometric training. But if you do plyometric training early, the muscle can't recruit, isn't strong enough, and the tendon won't cope with it. So then people sometimes ask me, I was asked a couple of weeks ago, do you still do eccentric training for your tendons? And for me, that's the wrong question. There are, it's when do you do eccentric? It's not an either or. It's not, oh, everyone does isometrics now, or everyone does eccentrics as we used to do them. It's, here are some options. Now, when do you select them for the adaptation you require? Isometrics are really good for reducing pain, increasing motor unit recruitment, reducing inhibition. But we live in the real world, so we do isotonic exercises all the time, so you've got to do those as well. Heavy, slow resistance training will give us good tissue adaptation and facilitate recruitment and maximum strength at the low end of the force velocity curve. But we've got to facilitate the ability to generate force at longer lengths and maximize tissue adaptation, so that's when eccentrics come in. But then also, if I engage in a sport that is multi-directional high speed, I have to do some plyometric type activity to facilitate adaptation and stretch shortening cycle. So it's not either or, it's when and how. Number 3, therefore, optimal loading has appropriate progressions. How can we progress our optimal loading? We don't just use a scattergun approach of one type of loading throughout our entire rehabilitation process. So what does progression of loading look like in rehab? Well, if we imagine our acute injury rehab through late stage rehabilitation, return to play, and then return to performance, in the ideal world, it looks like this, doesn't it? It's great. Everything goes nice and smooth, nice and linear. We get a great outcome. But I think most of us have been in the room, have probably been in our work long enough to recognize that that's not the real world, is it? And we have to consider, well, what do we know about progressions of loading and exercise prescription in healthy subjects? Well, we're all familiar with Tim Gabbett's work and all the great work that group have been doing, and the idea of the acute chronic workload ratio. And the idea that if you progress too quickly, that can be a negative. Similarly, if you don't load enough, you don't get the appropriate adaptation. So, in the real world, what I would argue probably happens when we return to sport is we go through our rehabilitation process with a stepwise progression of loading. We get an increase at late stage, then all of a sudden you return to sport and your load goes right up through the roof. Yeah? You play at a higher intensity, you train every day, and our loading increases. And what does our acute chronic workload ratio look like there? And for me, that's a real danger zone. So I would argue that perhaps some of our problems with recurrence, particularly in that first 6 months or the first 3 months or 50 days, if we're thinking about some of the hamstring stuff, is because we've increased our acute workload ratio compared to what we've been doing previously. And that, remember, most of the acute chronic workload ratio stuff is in healthy subjects, not in an injured population. So we then can choose to modulate the different types of loading, to moderate that load, to get the adaptation and progress those appropriately. So it's not just one big general metric for all loading, but we consider, well, what's my tissue loading look like? How am I increasing my loading of the neural system? What's my metabolic loading? What are the skill components and how are they being progressed? And what's the interaction and interplay of some of those different sub-factors? So what does optimal loading look like in rehabilitation in terms of progressions? Well, I would argue that we have a stepwise progression with periods of unloading to facilitate adaptation and recovery, and that when we get back to this stage of late rehab and return to play, we probably need to spend a lot longer in managing the load at this period of time and controlling the increases over time. I would argue or propose that that would facilitate and contribute to better outcomes in the longer term and minimizing recurrence. So what are the characteristics of optimal loading then? Well, we direct it to the appropriate tissues. It's through the functional ranges. So we're getting the right type of loading in terms of stress, strain, tensile load, shear load. We're considering the neural overload in the nervous system, and we make it tailored to the individual characteristics, unlike non-specific, generalized, non-functional loading. Because ultimately what we're trying to do is we're trying to increase the capacity of that person to operate in a number of different characteristics. So if our ability to perform is very narrow, when we add in other constraints like return to sport, task difficulty, environment, tissue load, then what tends to happen is that ultimately we will fail at our performance or get injured. But in our rehabilitation and our exercise prescription, we're trying to widen out the performance zone, the different environmental constraints under which I can maintain performance, so that whenever something happens, a load changes, or the difficulty of the task, or the environmental constraints change, then I will maintain a balanced system. So, what are we trying to do? What are we trying to achieve, I suppose, in summary? Are we trying to load to manage pain? What strategies, what mechanisms are you trying to stimulate? To address pain or loading strategies, we might use something like isometrics to facilitate analgesia, to maximize motor unit recruitment or reduce inhibition and facilitate a more pain-free movement pattern. Are we trying to increase tissue capacity? Well, our loading strategies may be therefore focused on changing the muscle tendon unit morphology, the stiffness characteristics. And for muscle, it might be increasing fascicle length, increasing the collagen reorganization, improving that through our loading strategies. That's tissue characteristics. We're trying to improve our movement capability. Our loading strategy may be, well, how does that integrate within our kinetic chain? How do I maintain appropriate tension within the system? Can I facilitate appropriate biomechanical sequencing of the proximal to distal segments? Am I facilitating the rate of force development or sport-specific skills? And as a model, I think, to consider our choice of loading, what adaptation are you trying to achieve? This helps guide our selection of exercise. So, in summary, our take-home messages. Well, our 3 points were optimal loading is early loading. Optimal loading has appropriate progressions and is tissue-specific and adaptation-specific. Number 3 has appropriate progressions. But what I would say is start early. Think of the journey ahead. Begin with the end in mind. Make sure it's tissue and mechanism specific. Make it progressive. Avoid sudden changes and think about logical progressions over time. Make the loading consistent so that it's not loading high one week and not in another week, but that you consistently load over and over again. Allow time for adaptation and continue this loading following return to play. So thank you very much for your attention this morning, and I just draw your attention to this conference we're having in Belfast.